Okay. Good morning, everyone. Yes. I hope even those who are online can hear me very well. So, my session, I will be taking you through the use of DHIS2 API to develop Tanzania immunization registry. I'll be the one presenting. However, there's also here in my room, in this room, there's Ismail, who is also who are also been part of this process. If there's anything that maybe you might need to know from more about this one, you can also consult Ismail. But you also have seen online, there is also another colleague from HISP Tanzania, Eric Chingaro, who has also been part of this process, the core developer of this product. So if there's any other technical clarification that you might need, you might also drop a message for those who are online, and Eric will help to respond to those issues or questions. So before that, let me take you through a little bit of a background and why I started putting the challenge. Because the Tanzania started wanted to go paperless through one of the program called IVD. I want to go paperless by digitalizing the immunization process or immunization registry. So there was a system that was adopted from one of the company that I'm not going to mention the name. That was called Team Revision 1. It was actually doing quite good. However, it also faced some critical challenges, and it was not developed under the DHIS2 platform. So it was another platform. So what makes so special for this one to be presented here? Now we replicated the same process in the DHIS2. Before then, it was not believed that DHIS2 is capable of doing the same thing that Team Revision 1 was doing. But however, with that Team Revision 1 that was seen to be doing quite good, it was having some technical issues. One was because, as I said, it was developed outside the country. It was not developed within the local expert pool that are available. So it suffered a lot in terms of getting technical support whenever there is an issue within the application. And this was the mobile application that was really designed to work offline. Because of the context of our country. And it was actually recording the immunization process from weight, recording weight up to the immunization. But it was also even doing more than that, including also planning of the session, but also conducting outreach. And when you are conducting outreach, you'll be most of the time not connected to the internet. So you have to be working offline. And then at later, you need to synchronize those information to the central system. But also, there are some critical bugs that were being reported, and one of it that also even witnessed because we are supporting the DHIS2, and this data was supposed to be coming to the DHIS2, but an aggregate, but was not being able to synchronize those data to the DHIS2. So it's one of the bugs that I also witnessed when we were doing the supervision, that there are several bugs that were being reported, but it was taking long time to be fixed. But also, as I said, when these healthcare workers they are conducting outreach session, most of them, they are offline. So they expect that after recording those information, needed to be synchronized to the system. And they also, it was a bit challenging, and which again brings the system being unstable in terms of performing those critical functionality that was being needed. So due to that, and then because it was already being scaled up to 15 regions, and Tanzania we're having more than I think 26 regions, so it was almost more than a half. So because of those issues, and then it was stopped, and then we resumed using the paper tools, the registers, where you have to go and put in the register, at the end of the month, they have to tally and then need to put those aggregate number into the DHS. But still, the government wanted to go paperless, wanted to remove or to not to have healthcare workers have more work to do in terms of at the end of the month, you need to kind of being able to summarize or to come up with this aggregated data. So the ministry wanted to proceed, but for this time we wanted now this platform to be implemented within the DHIS2 platform, and that's where we were able to come in and be able to rescue this. So I'm going to share what did we do. Again, this one was supposed to also being able to come up with the mobile application. Of course, the question would be like, because at the end we ended up customizing the mobile application. So the question was like, why don't you use the existing DHIS2 mobile application? But again, there's several toolkits that has been developed. Why did you maybe not adapt or adapting the existing mobile the immunization toolkit that is already there? So there was a reason why we didn't do that. First of all, was to customize or to digitize the whole process of giving immunization. As we all know, the toolkit that we are having, it's like a line list kind of register. It's like everything is done in a parallel, or at the end, a person has to enter the record at once. But for this one, was a little bit different because apart from recording the immunization data, first of all, was to make sure that the facility have a stock of vaccine. Because the way how it's being done there in our country is that before providing the vaccination service, is that you need first to be able to estimate of how many clients are going to come to a facility, and you need to specify which session that are you going to be doing. Either it's a fixed or it's an outreach. So through that, you need to make sure that the stock is there, and then you need to prepare of how many these antigens that are going to provide, by also specifying the number of doses depending with the client. So before that, you need to also to have like a planning of what to know the estimate of clients that are coming for your facility. So after that, and then after knowing all of that, you need also to because the facility has this process of planning the session. Like for the whole month, we are going to have maybe 20 fixed session, and then you are going to have maybe 10 outreach session. So when you are doing the vaccination, you need to start a session, and then at the end, you can be able to evaluate the session planned against the session that was being conducted. So you have to go all of those process of doing the immunization. But another interesting thing that when it's the time of or the day of providing session, you need to start to specify, like in terms of there's different validation that you need to do, because at the end you also do the adjustment of those stocks. Like you said, BCG, I'll be maybe providing maybe 40 doses, and you need to know the behavior of the BCG, for example, because for the BCG, once you open it, you can't take it back to the fridge. So all of this has been also counted, where you cannot find that one in the toolkit that has been developed within the DHIS2. So that was the reason why we even decided to customize depending with the for the local context. So among the modules that we are able to develop is to track the stock level of the vaccine, and also other related supplies. And here, for example, when you are saying the BCG, we have other related supplies. Okay, like the syringe, but also you have other like, for example, if it's BioPV, you need to have the dropper and all of that. So all of that also need to be counted. And for the syringe, you have also the safety box, where for each safety box, it's only carrying 100 syringes. So when you have vaccinated maybe 100 clients, then you have automatically to say this has to be one safety. So all of those validation were also being taken into consideration to this application. But also another thing we had also to another module of session planning, but also knowing the session conducted, but also the whole immunization process. And here, it's really very interesting. As you can see, for this first, the one that I put here, like when you are registering a kid, then it's going to give you the plan of when that kid should also be able to get other vaccine. For example, as here, you can see like we have this plan, like the BCG, but also this BioPV, for example, and the dose 0. This have like it has to be provided within 14 days after birth. So if it happened that that kid was not given that dose within that 14 days, then it cannot be given. So this one, which means even the healthcare workers cannot be able to issue this vaccine. So it has a lot of validation, but also giving you also other plan. Like, so you will be expecting that at this particular date, we will be expecting this person to be able to come to get the vaccine. But also through that, we are able also even to send the notification. Like before that day, then you are sending the notification to the caregiver that you are supposed to bring that kid to get the vaccination. But also, as I said, through that immunization module, there are some facilities that with high volume of client, where you can find that you have a nurse taking weight, but also you have another nurse doing the vaccination. So the problem or the issue that was like, how are you going to make sure these two devices has to be synchronizing the data? Because the client come and then have to start here taking the weight of the kids, and then has to be put into a queue together. And then the nurse over there providing the vaccination will be calling depending on the queue. So how are you going to make sure these two data has to be synchronized? Then we are able to come up with a way of making sure these devices are offline, but they have to be exchanging the information. So through that, I'll come back there. Then you have to have this kind of, it was a little innovation because it was not even possible, or it was not there even the previous immunization registry, where you connect this device offline. First, you started exploring by using Bluetooth. How can it be this data once you have already, maybe weight has been put into the system? How is it going to be visible to the other nurse over there who is providing the vaccination? So we started exploring the use of Bluetooth, but also we started, now we come that because we thought of now using the local network. That, for example, of course, in most of the facilities have the internet, or even if there is no internet, you can also be able to tether the internet using your tablet. So then the other nurse over there providing the vaccination can also be able to connect to a network, and where even that there is no internet at all, then you can find that you are able to see the data from one device to another device. And this one works. We tested it, and it works within up to range of 150 meters, so within the facility or even there. So this was one of the interesting innovations that we did to make sure even those facilities with the high volume that are having different section in terms of providing vaccine, they are able to see the same client and they be able to work or to operate on the same client. So apart from that, apart from the mobile itself, then we are able to come up with this in which I think all of you know that the DHIS2 is really good in terms of analytical output, as you can see. But also another thing, one of the core functional to this immunization is that they also wanted, because at one of the reporting tool, it's asking to know those facilities that were within the catchment and those that were coming outside from the catchment. So how are you going to get that? How are you going to configure that in the system? So in our health sector, especially the immunization, they have this district immunization vaccine officers, where they know like this facility is supposed to serve maybe 3 villages around. So they also map. So if it happens like a client, when you are registering a kit, a client, and then in the place of domicile, for example, saying maybe I'm coming from another region, because the client are not restricted to go to any of the facility. They are allowed to go to any of the facility. So how are you going to know that this facility is actually coming from the other region? So through those mapping, they are able to know that. And who are supposed to do that mapping? So we created what we call the team lead manager, where the Devo now could also be able to do all of the mapping. So through this interface, as you can see, can be able to assign the facility catchment, but also there was other functionality that was really being required. For example, facility duplication, because there are some duplication. But also another important functionality that we did is having this barcode. This helps in terms of searching, because you know you have a pool of a lot of clients. How are you going to make sure that you can first search, be able to proceed with the other? So this system are able to provide, to generate the barcode, and those barcode, they are being put in the card, in the clinic card. So when you go to the other facility, no need of starting searching. You just open the app and then you search the barcode, and then you get the information, and the other process will proceed. But also other reports like a defaulter and being able to identify the defaulters, because and this how to identify the defaults is like you need to know, like, because you have been issuing the message, the notification to come for the next dose, and they found that the client has not appeared to the facility for 28 days, and then is being regarded as a default. And then the community healthcare workers, they are being notified to follow up, to know what is happening, why that particular client is not there. So the implementation process has been actually the same thing. First, we started with collecting the requirement, but coming up with the prototype. So we started coming up with the wireframe, presenting to the MOH for them to be able to buy in that this is the nice interface that we can proceed. And then the phase 2 was the development, where we constantly had this meeting with the stakeholders to know if we are in a right track. And also at the end, we did the UAT, where they were able to go through all the functionality, where we got a lot of comments, and then be able to fix all of them. So the first thing that we are in, we are doing the pilot. We have identified 10 facilities to start to see how the application is going to really behave. But also, the immunization or the MOH have other several systems that is actually contributing to this immunization data. One of it is this VIMS, which is called Vaccine and Immunization Management. This is for stock-related and the supply chain for the immunization. So this, the phase 4 will be now expanding or integrating with this system, the VIMS, to make sure that the data are always available, the stock are always available to the tool. But also the GoToHomes, this is the EMR that has been developed, that is working to some of the facilities. So we have to make sure that it has to be exchanging the data, because those clients, they can be able to visit any facility they say the area. So whenever they go to the facility that is using GoToHomes, those records should also be there. And those that has been served with the GoToHomes system, when they go to another facility that is using Teamly, we have to make sure that those data are there, and then the continuation of the service has to proceed. So another is the integration of the DHS, and this is actually for the monthly reporting form. So to make sure that the analytical kind of report can also be produced with also the HR. So I think that's will be off for me. I've been informed that I've been 1 minute. Maybe I can talk a bit for 1 minute. Yeah. So the challenge that we are able to really get rid of. Now, the tool that you have developed is advanced one. It's even beyond the previous tool that was able to provide. But the good thing that now this tool is working on top of the DHS tool. So you see, there will be an advantage of the only recognized system for the nation is the DHS tool. But also, if you are building on the top of the DHIS, so there are some will be working seamlessly because they are all the same platform. But also in terms of connectivity, as I said, now we are apart from we know the capability of the mobile, but also with that being able to connect offline between the devices, it's also going to help a lot. But also integration with the vaccine stock management system that now the healthcare workers will no longer, or we don't need to enter the commodities or the stock within the team. So we'll be just pulling what is already there in the VIMS, the vaccine immunization management system, to the team. So thank you very much. And
okay, thank you so much. This one, okay. All right. There. 2 mics. Sound test so I can.
Okay. Hello. Okay. And how to next it? Okay. 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 Thank you. Thank you and good morning. Today I will be presenting our work on revolutionizing TB surveillance in Pakistan through custom solution for efficient user and facility management. But let me introduce myself. First, I'm Dr. Bilal Ahmed, and I'm working as Chief Surveillance and Information Management at Common Management Unit, Ministry of National Health Services Regulation and Coordination. So the Common Management Unit basically is the PR for HIV, TB, and malaria, and is playing a pivotal role in accelerating the national and provincial response toward achieving the SDG 3. Regarding the tuberculosis is one of the major public health concerns in Pakistan. Currently, we are reporting almost 0.5 million cases. The TB surveillance system launched through DHIS through tracker capture in 2021 and integrated both the public and private sector. Currently, we over 13,000 health facilities are reporting through DHIS2 with 2,300 users to streamline the TB case reporting and monitoring. Okay, so the national TB case-based surveillance system achievement so far, we have 2,327 active users, 1175 data entry operators, in which the private sector is 51% and the public sector is 49%. We have through this DHIS capture system report notified 3,85,000 cases, 45% from the private sector and 55% from the public sector. As far as the coverage is concerned, we are the coverage of DHIS2 in malaria intervention districts is 81. For TB, it is in 157 districts, and HIV, it is in 95 districts. The total districts in Pakistan are 186. So out of 186, these are implemented for 3 diseases in these districts, and total of 13,868 health facilities are connected through or reporting through the DHIS2, in which 90% are private and 10% are public sector. So for every scale, there are challenges, and the challenges we faced while scaling up the DHIS2 to this extent, that we were managing 13,000 health facilities and 2,300 users at the center level, at the CMU level. And we were receiving frequent requests for reassignment and role updates, especially in the private sector. In the private sector, we have the district facility focal persons, and their domain, their GPs are the private health facilities are changed frequently. So we were receiving these requests on daily basis, and we have to do manual operations, and we had to maintain the accuracy and timeliness in data reporting, and there was a need for automation and error reduction. So what we did that we developed this custom DHIS2 app for facility and user management. You can see at the top, we have custom user interface, which include three main components: the admin portal, the organization management, and the user management. These modules allow system administration to perform bulk action easily. All these modules interact with a middle layer of custom APIs, which act as a bridge between the interface and the DHIS2 core. These APIs then connect to DHIS API layer, which communicate directly with the DHIS2 database. The system pulls data from DHIS to display facility user mapping, and when changes are made, it pushes updates such as facility reassignment or role change. So what we achieved is the bulk facility reassignment, bulk role update, and real-time data sync. This was okay. So the impact, you can see that there is a gradual increase in TB case notification over the time since the introduction of this TB case capture system in October 2022. There is a gradual increase, and we have reduced the administrative workload at the central level at CMU through this custom app, decreased manual error. We were able to improve efficiency in user and facility management and faster and more accurate TB data. Regarding the broader implication, we have shown through this app that this can be replicated to other diseases programs such as HIV, demonstrates scalable API-driven extension in DHIS2, supports sustainable health data management. Okay, integration of public and private sector. With this integration, we have strengthened the TB surveillance in Pakistan. Custom DHIS2 app address operational bottlenecks, continue to support national TB control program, and now we are in the process of developing or replicating this app for drug-resisting TB. So this was for a drug-sensitive TB, and we are replicating it now in drug-resisting TB surveillance system. So these are the system interface highlighted, user and organization management. I would request Adnan to go through it. These are simple, just okay.
Thoughts of the of the um of the interface that Common Management Unit has developed. So we'll quickly go through them. So it basically manages the users, even sees the org units, and even assigns the org units to them. It also has, this is basically when you are registering a unit, you can basically enter the org unit code, name, and then you can register the user over here. The reason that this was developed was basically DHIS2 doesn't support multiple org unit hierarchies. That was one of the reason. I mean, in Asia, we have been requesting this this feature for a long time. So we didn't want it to give access, maintenance access to the private users. So for that, we then had to developed this custom application, which basically the private users log into, the private admin users log into, and they simply add users. They can add it in bulk, they can add it separately, and then through APIs, the user is automatically added into the DHIS2 core. Thank you. Any questions? Okay. Over to Ellen.
Thank you so much. And reminder to our participants online, if you have any questions, please go ahead and ask them in the chat. We will take a look.
Good morning, everyone. Good morning. Great. Thank you. Thank you. Good morning, everyone. Great. My name's Stephen Nonde. I'm a data translation specialist with the Zambia National Public Health Institute. I'm excited today to present to you our experience in developing and implementing the Automated Surveillance Alert Program, which is an enhancement of DHIS2 to be able to send structured alert notification to district surveillance officers. My co-authors' names are Ruben Kaponde, who is an informatics engineering specialist at ZMPHI, as well as the architect of the external program upon which this innovation is built. Zambia, since 2020, has been using the Electronic Integrated Disease Surveillance and Response System, EIDSR, which is a DHIS2-based program to collect routine surveillance data on priority diseases for our indicator-based surveillance, IBS. IBS data is collected primarily through two modules. The ND1 or case-based module, which is shown on your top right, collects detailed information about individual cases as and when a case is identified or meets the case definition. The second module, the ND2 or aggregate data module, is used to collect aggregate data on the number of suspected, tested, and confirmed cases on a weekly basis. In Zambia, this particular module has been used for a longer period of time and represents the most up-to-date reporting when it comes to priority diseases. And for that particular reason, it is the module upon which this innovation was built. So, despite EIDSR or DHIS2's use for surveying priority diseases, in Zambia, it has not been fully utilized as an early warning system. One of the main reasons for this is that DHIS2 has limitations when it comes to computing complex thresholds. For example, thresholds such as doubling of cases in 2 consecutive weeks or detecting a 1.5 times increase over a 3-week baseline. But perhaps even more crucially, DHIS2, while it's able to send system notifications, and you can see that in the screenshot on your right, this particular user has over 6,000 system notification. DHIS2 has limitations in ensuring that these notifications only target the affected district when a threshold is surpassed. And also, related to this same particular challenge, these system notifications cannot be structured in a way that allows district surveillance officers to take additional actions, such as verifying the alert or tracking 717 metrics. We were also motivated by Zambia's commitment to the 717 performance metrics, where countries commit to detecting, public health emergencies within 7 days of emergence, notifying relevant authorities within 1 day of detecting that public health emergency, and lastly, initiating and completing all early response actions within 7 days of notification. So what did we do about this? We developed an external application that regularly pulls weekly surveillance data from DHIS2 via the DHIS2 API at defined intervals. This particular program performs thresholds analysis to determine whether a threshold for a particular disease has been surpassed. And if the threshold has been surpassed, the program generates an alert ID, enrolls the alert into a DHIS2 tracker for additional action, and also directly notifies the district surveillance officer via SMS, email, as well as the Telegram application. We also, using a participatory approach, reviewed and defined thresholds for pre-selected conditions. We applied a single suspected case threshold to acute flaccid paralysis, AFP, anthrax in non-endemic areas, viral hemorrhagic fever, as well as yellow fever. We applied a doubling of cases in 2 consecutive weeks to non-bloody diarrhea and COVID-19, and we applied the 1.5 baseline increase over a 3 weeks baseline to bloody diarrhea and trypanosomiasis. Lastly, we also applied a cluster of cases threshold to food poisoning, at least 2 cases, and measles, at least 5 cases. Using a participatory approach, we also developed standard operating procedures, which we validated by continuously engaging surveillance officers at national and subnational level. Currently, this program is being piloted in 2 provinces across 26 districts. This particular slide shows the system flow of how the external program interacts with DHIS2, and starting at your left, data, weekly aggregate data is put from DHIS2 via the DHIS2 API into the external program, which performs thresholds analysis by just determining whether a particular threshold for a pre-selected disease has been surpassed. If that is surpassed, as I mentioned earlier, an alert ID is generated. The alert is enrolled in the DHIS2 tracker program, and the district surveillance officer is notified via SMS, email, and Telegram application. The district surveillance officer is then required, as you will see again on your left, is required to update the alert tracker or DHIS2 tracker program by verifying whether the alert that they've received is a true event or if it's due to a data entry error. If it's a true event and it's not due to a data entry error, they update the tracker and all verified events are then pushed into Zebra, which is yet another DHIS2 program that we are developing that allows monitoring and management of public health emergencies. Zebra actually stands for Zambia's Emergency Bridge for Response application. The next slide depicts the workflow that we had to develop as part of our standard operating procedures just to promote the use of this application and also guide district surveillance officers on the steps that they would be required to take once they receive an alert. The first step is to validate and verify the notification. So once the notification is received via email, Telegram, or SMS, the district surveillance officer may be required to log into DHIS2, review the data for the previous week, and also contact the primary source of that particular data just to ensure that it's not due to a data entry error. Based on the results of their verification, they are then required to update the DHIS2 tracker program by filling in required fields, as well as changing the verification status, which by default is pending verification. So they would be able to update it to either verified as a true event or discarded due to a data entry error. The third and final step is initiating early response action. And this is only done if the event is true. The district surveillance officer is then required to initiate all relevant response actions using the 717 metrics, using the integrated disease surveillance and response guidelines, using the action incident action plan if it's already in place, as well as other disease-specific or emergency-specific protocols that apply to that particular alert. This next slide, I would just like to show you how an alert looks like. You have the alert ID at the top. You also have the alert notification message content. And in this particular instance, this is an alert related to a cluster of measles cases at Chindi Health Post in Zimba in Southern Province. And you also see that a link to the DHIS2 tracker program is also provided in this particular message to allow the district surveillance officer to perform the additional actions. In this slide, I would like to show you how the DHIS2 tracker looks like. So some of the fields are pre-populated, such as the alert ID, the condition or disease, the national FIOC status, which by default is at watch, as well as the verification status, which I mentioned earlier, is also by default pending verification. So based on their verification results, they would then update this tracker and complete all relevant fields. The next slide just shows a dashboard in DHIS2. As of 2 weeks ago, when I sent this presentation, we had a cumulative of 231 alerts that have been generated since January when we started piloting this program. The DHIS2 dashboard is used by the surveillance officers as well as the team at national level that is monitoring this program. We have a line list shown at the bottom there of the alerts that have been generated in the last 7 days. We also have a line graph just showing how the alerts have been generated over the past few weeks. We have also made use of Superset just for closer monitoring of these alerts. And I would maybe just like to point out here that we have alerts that have been verified as events as 42%, alerts that have been discarded after verification at 29%, bringing the total of our verification as it stands 2 weeks ago at 71%. The median time taken to update the DHIS2 tracker program is 1 day, but I should mention that this is self-reported. And the median delay taken for alerts that are still pending verification is about 53 days. This particular slide just shows the distribution of the alerts by condition. And you will notice there that the majority of the alerts that we've received so far have been related to diarrhea with blood, 56%, followed by food poisoning, 26%. But you will also notice that these verifications vary by condition. So in conclusion, I would like to say that by developing an external program, we've been able to address DHIS2's limitation in computing complex thresholds, as well as sending targeted and structured notification to district surveillance officers. Also, by using a participatory approach, we've been able to see that This particular program has been seamlessly integrated into routine surveillance operations, both at national and subnational level. We did not necessarily introduce anything new, but what we did is just automate processes that surveillance officers are required to perform. Lastly, our initial findings are also showing that it is possible that through enhancing DHIS2 and refining workflows, it is possible to actually improve coordination between surveillance teams as well as response teams. You will agree with me that this particular program has sort of created a bridge between detecting public health emergencies and then subsequently tracking and responding to them. We believe that this particular experience can be, or this particular model can be replicated in other countries that are looking to strengthen their surveillance capacities. Thank you very much. Thank you.
Okay, thank you so much to all of our presenters. Do we have any questions in the room? We have a few minutes remaining. Okay.
Helen, I just wanted to ask you, because from our experience, we know that DHIS2 also can set certain thresholds and also can issue notifications. So why custom solution? What was the specific limitation that you were looking for?
Very much for that question. As I mentioned in my presentation, we opted for a custom solution for two reasons. I was informed by the informatics specialists that there are limitations with DHIS2 in computing complex thresholds. And the examples I gave is the doubling of cases, for instance, across 2 consecutive weeks. And the other is a 1.5 increase over a 3 weeks baseline. But more crucially, the system notifications cannot be structured in a way that allows the other parts of our workflow to be executed. For example, the verification of the alerts, as well as the tracking of the 717 metrics. So that is the reason why our engineer opted for a custom solution as opposed to using system notifications that are inbuilt in DHIS2. Thank you very much.
Okay, I see another question here.
Thank you, Stephen. I have 2 questions for you and the gentleman from Tanzania. Are there timelines, since there is a human touch to the verification process, are there set timelines for verification for the alerts from the districts and the healthcare facilities? And then for the gentleman, I'll just share maybe a bit of context. For example, in Uganda, some facilities have more stock of some vaccines than others. And then the districts always ensure that there is redistribution done across healthcare facilities, so that those that have more can share with those that do not have. So how do we handle this redistribution using the beautiful immunization registry? Thank you.
Thank you. So there is a timeline. District surveillance officers are required to verify within 24 hours. But obviously, we are experiencing some challenges. And you saw in my presentation that we have alerts which have not been verified with a median time of about 53 days. This is a pilot, so we're still learning a lot. A lot of what is expected of the DSOs may be refined or changed by the time we close out the pilot. Thank you.
Okay, thank you very much for the question that you have asked. This immunization registry works at the facility level. And there's also another system called vaccine immunization management system, which handles all of the or the supply chain related to the vaccine stock. So the district immunization vaccine officer, we call them DIVO, the one that do all the distribution of those vaccines to the facility, or the facility that belongs to his district. And the way how it's being done, and for example, because they're using the mechanism called pull request. The pull request is that for the team lead, it's just giving the a notification if you have reached the reorder level. Okay, so if the facilities have reached the reorder level, then it has to send the request to the district level, where the DIVO, or district immunization vaccination officer, has to assess if the order that has been requested is really enough, and that one is also being compared with the number of clients that facility is actually serving. It's like the average. And then if there is, it looks if showing that in the system you are still having enough stock, there's a possibility that might not have been given the stock until you specify what happened to the stock that are there. Have them been maybe expired, or the VVM is a bit having high number that cannot be used, and all those are factors. And in the immunization registry, there is also a place where you need to do the adjustment. You need to specify how many of them has been expired, and how many of them maybe VVM has gone high because due to the temperature and other factors. And then the DIVO then could also send you another stock. But also you are still having the flexibility of also going to borrow to the nearest facility. In case DIVO can tell you like the nearest facility has a lot of stock available, and probably for us to be able to maybe to bring the commodity into a facility, maybe it might take time. So you are allowed, or you are also allowed to go to the nearest facility to be able to borrow. And then you need to come to the immunization register to be able to adjust like for the inventory in, and specifying that I borrowed this from the nearest facility. And even to the other facility over there, where there was inventory out, they also have to do the adjustment to make sure that this calculation has to coincide at the end. Yeah.
We have a question online, if I can read that one really quickly, from Adrian, who asks, do we have time for a few more comments about Zebra? I understand that it's also based on DHIS too. I think they were just asking for a little more information about Zebra.
So Zebra stands for Zambia's Emergency Bridge for Response application. This is being developed with support from Resolve to Save Lives. And this particular system will help with monitoring as well as managing public health emergencies. So on this particular platform, response teams will be able to look at events that have, or alerts that have been verified as events, monitor them, be able to do risk assessments and risk characterizations, and qualify them as national events. Then they will be also able to create what is known as an incident management system and assign roles within that IMS for the management of national events that have been identified. Thank you.
Super. Thank you very much. And we have one more question in the audience here.
A comment and a clarifying question to Tanzania. You mentioned that the trigger for order was stock level, but I assumed it was periodic. So based on a certain amount of time, because distribution is periodic in Tanzania. So if you could clarify that. And the quantity is based on stock level, I assume. The comment I have is to just applaud Tanzania for something unique that you happen to be doing that you haven't maybe mentioned, is that because your system has both health service information and logistics information, you are able to calculate usage rate, which is the opposite of wastage rates, open vial wastage rates. And that is something that is unique to many systems, whereas other countries have to go out and do ad hoc surveys to understand what wastage rate is because it's not commonly reported. What your system does with its checks and balances is ensure that the information is available because the doses that were not administered and have left the system through the logistics data, you can see what actually went and into open vial. And I don't like calling it wastage, but it's opportunity for vaccination where it was open to provide vaccines and the rest went to waste.
Yeah, thank you very much. Yeah, of course, the time was not enough to go all of the functionality. And as you have seen, I was being shown like you have only 1 minute. Was still having a lot to say. But at least you got the picture. And coming to the one that you said, yeah, it's not like they have to be issuing this pull request every time. It's of course periodic because the facility healthcare workers has been trained to be able to know how long they should be able to request for the vaccine. And I was saying like in case like there's an emergency, and that of course we got that there was a poor planning before because it was not supposed to have an emergency. But if it happened that it reached the reorder level, because the reorder level, it's like you are still having the stock you are having can be able to survive for 2 weeks. That's the reorder level. Is giving you the threshold that you need to reorder because the stock you are having can be able to go up to only 2 weeks. So you don't need to reach. So when you reach the reorder level, which now, if you have planned very well, that means it will be the time that the DIVO, the district immunization and the vaccination officer, will be able to distribute those commodities to your facility. But you can still be able to, if it happens, maybe there was expiring of vaccine. That's where you can issue. And because the team has given you the flexibility of being able to adjust, and still the DIVO can be able to access those information. They can also be able to know what is happening, even if you haven't even informed them. Okay, yeah.
Thank you very much to all of our presenters, to our attendees, and those who have followed along online. I hope you enjoyed this session. We have a coffee break now, and then the next session resumes in about 10 minutes.